Uh, Today we have a list of estimable speakers, healthcare professionals who lead in their own spaces, in their own respective areas, who are going to talk about the various aspects of the healthcare ecosystem, the challenges and the opportunities. These are visionary leaders uh, who have added value in the healthcare ecosystem in their own spaces. Alhamdulillah. Uh, I would like to see how many panelists have already joined. So we have Professor Saeed Akhtar Saab. Uh, he has joined us from Islamabad, I think. Welcome, Dr. Saeed Akhtar. We have Professor Dr. Abdul Bari, CEO of Indus Hospital. Uh, and I think we are waiting for a few more guests to join us. Yes, we have Professor Dr. Arshad Taqi Sahab. He has already joined us. And so we'll just wait a few minutes for all our respected panelists to join. And then we will start off with a prelude. So maybe another few minutes, inshallah.
वालेकुम भाई भाई क्या हाल चाल है?
वालेकुम अस्सलाम, कैसे हैं आप? खैरियत हैं?
ये लगे
कहाँ इस्लामाबाद में ही हैं सर? चले, मंडे को मैं इस्लामाबाद आ रहा हूँ. मैं कोई वक्त होगा तो आपसे कोई तय करके मिल लूंगा आपसे इंशाल्लाह.
बहुत अच्छा हो.
I think we can start off with the session while the other panelists join us. So with the name of Allah subhanahu wa ta'ala, Bismillahir Rahmanir Rahim. Qul huwallahu ahad, Allahu samad, lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. We start the first plenary of ICON 2022. First of all, it's my honor and privilege to moderate this important discussion and conversation on healthcare ecosystem and healthcare systems with these visionaries in Pakistan, mashallah. To start the conversation, the Indus Hospital team has created a very short video. So if we can have that video. Khalid Mahmood Saab has also joined us. Thank you very much, Khalid Saab, for joining us. So please, if we can have that video to start the conversation.
Our world has changed. Our world has changed. Our challenges are greater. Our challenges are greater. Our vulnerabilities have been exposed as a result of the COVID-19 pandemic. The time is now to synergize and bring about an exchange in the global health ecosystem. Challenges all over the world are the same. Antibiotic resistance. Physician burnout. Hospital-acquired infections. Let's come together globally and explore opportunities to make this better world for our people and the humanity. Create synergies and digital transformation. Orient our healthcare systems towards provision of patient-centered healthcare, sharing of cutting-edge technological solutions, data-driven research and development.
Thank you very much. So to start off the conversation, and as a moderator of this session, I again want to welcome and thank all of my panelists who have joined us, and a few more panelists who will be joining us very soon, inshallah. So the format of today's plenary is that I will make a very short presentation to set the stage around the theme and the topic and the conversation. And then All of our panelists will speak from their own experiences and perspective for around 10 minutes. And then we have an open, interactive discussion, question, answer, conversation, inshallah. Without further, delay, I will start the presentation. Bismillahirrahmanirrahim. So today we are going to talk about the global healthcare perspective, the challenges and the opportunities. And as you can appreciate from this slide, which actually summarizes the whole situation, or what we have done is we have tried to summarize. It is not 100% inclusive representation, but we have tried to point out or gather most, if not all, of the challenges and the opportunities in just one slide. And as you can see, that physician burnout, medical errors, antibiotic resistance, silos in control, double, triple disease burden, costs. These are most of the burning challenges which are limiting healthcare in different ways, as opposed to two opportunities we'll be talking about a little bit, and the panelists will share their perspective. So a little bit about each of the challenge. Unfortunately, we all know that antibiotic resistance starts very, very soon, and the whole world is now struggling. The WHO has made a statement that we are entering a post-antibiotic era. The numbers are alarming, and very soon, unfortunately, God forbid, we may enter into an era where simple infections will kill us, our family members. And if you look at this slide, I think this is a very significant statement mentioned so many years ago by Alexander Fleming himself. And the last statement, I think, requires our attention, especially for the conversation which we are going to have today. I hope this evil can be averted. The evil of not using antibiotics judiciously by healthcare professionals, by pharmacists, by the society, and not being, regulated by the government as well. So it's a very alarming statement which this visionary made so many years ago, because he envisaged that healthcare, with all of its limitations and challenges, this is the challenge which we are going to face very soon. There's another, problem which the whole world is facing, including Pakistan, which is physician burnout. And as we all know, that COVID has actually added to this problem in many ways. Unfortunately, in the US, more than 400 physicians commit suicide every year. That's more than one physician per day. So that, again, is a very alarming situation. And these are physicians who actually end up taking their lives. We are not actually taking into account those who are chronically depressed or who consider taking their lives. Similarly, the double or the now triple disease burden, communicable diseases, chronic diseases, infectious diseases, and malnutrition have added to the burden and added to our challenges in healthcare. We all know that healthcare is one of the most, if not the most expensive area out there. In the US, this industry, as they call it, is more than $4 trillion. And all over the world, it's more than $8 trillion. It's a very expensive area to work in. Similarly, as WHO mentions, 1 out of 10 patients may be harmed while in a hospital. We call these preventable medical errors. And so much so that in the US, the third leading cause of death is now not a disease. It is preventable medical errors, which perhaps will become the first if the way things continue. This is the first report, as we all know, which came out in 1999 and which told us or informed us that preventable medical errors is an issue. And the topic or the theme of this report was very, very relevant to us as humans, as physicians, as healthcare professionals. We are bound to make mistakes, but we need to improve our systems. But the numbers are alarming, as we can appreciate. This is a slide, again, to create a context and a perspective that this is how many people who are dying every year globally because of preventable medical errors, and we are yet to manage this. I wanted to share this slide because as soon as the first report came out, a few years later, Institute of Medicine came up with this another report, Crossing the Quality Chasm. And in this report, for the first time ever, they mentioned one of the fundamentals of healthcare as patient centricity, which we are going to talk about, and the panelists will also talk about in detail in their talks. So BMJ has led this journey globally, and the statements are very, very self-explanatory: partnering with patients and let the patient revolution begin. I think that's the change which is happening in healthcare as an opportunity. Another visionary who talks about the role of technology in healthcare, and today, if you see, all of the technology companies are working and investing in healthcare. This is a slide which I created to give a perspective that it is not just recently that technology is helping us. If you look at technology, it has always helped us throughout the last maybe 100 years, and we have benefited from technology in various ways. Some of the people think that telemedicine is a recent phenomenon, but this slide and the next slide, which we have actually created for today's session, tells us that it's been happening for a very long time. Yes, COVID has become a catalyst, or it has actually accelerated the uptake or the adoption, or even eased off the regulation around telemedicine in the Western countries. But the telemedicine had been there for a very long time, and this is what we have recently created. That starting from 1876, technology has been trying to play a role to add value in healthcare. And alhamdulillah, in the recent years, the adoption has increased a lot. Uh, Again, this is a slide which I thought that will help us in today's conversation when we are talking about the challenges or the struggles in healthcare. Professor Lucian is a professor emeritus at Harvard, and he's considered as the father of the modern patient safety movement. And if you look at his statement, as we saw Alexander's statement, he says that modern healthcare is the most complex human activity there is. And I think the statement that we have not figured out how to make that work well will help us in today's conversation. Why are we struggling in healthcare? Despite technology, despite spending a lot of money, despite having all of these big hospitals, especially in the Western countries and also in Pakistan to an extent, why are we still struggling? Why are we still failing in healthcare? There must be something which is missing in healthcare, and that's the conversation which we wanted to have today, and that's why we invited these visionaries from their own perspective. We will try to address the gaps, that what is it that we are missing on? Is it only that if we spend a lot of money, then healthcare will improve? Is it that we create or establish many tertiary care hospitals? Will we be able to provide proper healthcare? Or is there something else which needs to be changed? I added this slide again to give a perspective that we used to work on the triple aim. The Institute of Health Improvement came up with that model. But now we have added the another aim, and now we call it the quadruple aim. And if you look at the fourth, it is healthcare team well-being. So it is not only that we need to provide care for the patient, but we need to care for the provider as well. I think that again creates a different perspective, and some of our speakers, I'm sure, will shed some light on this specific perspective. That is it only important for us to look after the patients, or is it also important, equally important, to look after the providers as well? So with this new model, which I summarized in this slide, again giving you a very brief snapshot that how the old medical model has changed and evolved into the new patient-centered model, and again, giving enough food for thought and context for today's conversation. So with that, I would like to stop here, and then we will start off with our panelists and learn from them and from their perspectives. First of all, I would like to invite Professor Saeed Akhtar Sahab, who will introduce himself. You know, he is again one of the visionaries. We are all very honored to have Saeed Saab in Pakistan. He has served healthcare tremendously. So, Professor Saeed, I would request you to kindly introduce yourself the way you want to. And then, please, in the next 10 minutes, we would like to learn from you with this as a backdrop, which I've just presented, and your thoughts on how we can improve healthcare with keeping in mind these challenges and some opportunities which we talked about. So, Professor Saeed, over to you. Uh, we cannot hear you, Professor.
Thank you, Dr. Zaki and Dr. Bari, for inviting me to this August meeting. My name is Dr. Saeed Akhtar. I'm a urologist and a transplant surgeon by profession, but I'm also an epidemiologist. And my area of interest is not only doing transplant surgeries and urology, but how to create systems in Pakistan and how to actually go towards the prevention side, uh, which also is very relevant in terms of the epidemic or pandemic that we are going through. I did my master's in public health from Yale University, did my training in New York, residency for urology and transplant surgery. Then I was chairman of urology and surgery at Texas Tech University and a fellow at University of Minnesota. Came back to Pakistan, laid the foundation of Pakistan Kidney Institute, followed by Pakistan Kidney and Liver Institute, PKLI. And right now we're in the process of developing another institute called International Medical Research Institute in Islam. So first, I want to start by saying that I think I want to pay tributes to our fallen heroes first, who have really laid their lives in the line of duty, serving humans across the globe. Uh, they are doctors, nurses, paramedics, physicians, surgeons, uh, police officers, sanitary workers, etc., etc. Government officials. Everybody has played really a key. Since we are talking about this whole conversation with reference to an epidemic that we are in, I think I, as a optimist person, always look at the opportunities that arise out of any calamity. And I think this epidemic has taught us a lot of major lessons: what to do, what not to do, how to deal with situations. And I want to start by sharing a little story with you. When I was at Yale, we had a WHO serum reference bank, and they would bring the data from, they will store the serum of any unknown epidemic, and whenever a similar epidemic will break through anywhere else, they will test and see. And there was a guy named Dr. Tigner who actually discovered the first epidemic of Congo Crimean hemorrhagic fever that took place in Pakistan. And he was always share his story with me with a lot of pride that I'm the one who diagnosed Congo virus. I think it was 78 outbreak. And from there onwards, I got the exposure of P4, P5 kind of labs with the space suits and whatnot, working on various viruses and whatnot. So this exposure and then preventive measures really gave me an insight of that. On one hand, I'm a transplant surgeon, but our way out, especially in Pakistan, is not towards transplant surgery, or obviously we have to do them as well, but is to go towards the preventive side. Typically when an outbreak takes place, it starts with a cluster, then it becomes maybe an epidemic, and then maybe a pandemic. And we have learned a lot of lessons from our SARS-CoV-1 and MERS virus, and we have really learned that there's no way you can treat them. There's no way you can get out of them. You have to take the preventive measures. And the reason why Middle East and Southeast Asia really had a better response than even West was because they were better prepared because of their exposure to SARS-CoV-1 and the MERS-2. And we are very lucky today, despite the fact that we're in the middle of pandemic and we are not sure what our fate is going to be. But the way things are heading right now, if we were not technologically as savvy as we are today, if we had not developed a lot of basic infrastructure in healthcare, and that includes, and I think we got a lot of uh, information from the project Genome, which really gave us the insight of what we are, how the cell works, how the nucleus works, and then a lot of technology came into the picture. And as Zaki was saying a minute ago, that now we have next generation sequencing. We know there was time it would take months to culture a virus, and now we can identify a virus in very little time. There was one time when I used to uh, make monoclonal antibodies. It would take me months and months and months. And now with modern technology, so I think we are very lucky actually. And if it was not for this technological advancement that took place in the last 30, 40, 50 years, we probably would have seen the mortalities and the morbidities in millions and millions more than what we are actually seeing. So that brings home a message that in Pakistan, and I would specifically, since we are in Pakistan, I would ask myself a question: are we really prepared? Are we really technologically as savvy as we should be, or are we the people who would be continually asking for help from others and not doing on our own? So I think this event should be taken as an opportunity to turn the fate of our destiny and learn from the world, and then I think grow ourselves. So what we have learned during this pandemic, I think as Zaki mentioned, IT was always there, but I think we have seen a completely new face of IT in terms of helping out in a lot of ways that did not exist before. We know it has become a norm to work from home. It is norm to communicate with on Zoom meetings. It has become norm to see a patient on through the telehealth that we've been doing for years. But I think this epidemic has given a great perspective of how to really improve our practices and deliver better and safe healthcare using the technologies that we have. So we have now molecular biology techniques, gene sequencing, production of monoclonal antibodies, and look at how we produce vaccine in a very, very short span of time by targeting a specific gene and its protein expressed on the virus. I mean, this is an absolutely heartwarming and very promising thing that had happened, and had it not been because of this, we would have been in really deep soup in our technological these
रेस्ट्रिक्शन से क्या आपको अब्दुल अख्तर
unprivileged country.
वीडियो बंद कर
So I think coming
नहीं
to
नहीं हाँ, वीडियो बंद है मतलब हाँ,
uh,
वीडियो बंद
uh, right, so then we have seen a barrage of new antivirals that have come into within this short span of time, and now we are seeing more oral antivirals which are coming. So what, and then new PCR technique and rapid antigen are more diagnostic tools. So I think if we survive this pandemic, and we will have some time down the road talking to our grandkids and telling them how we actually sailed through this pandemic, I think we'll be able to tell them with a lot of pride how we manage. But I think when we look at the perspective of Pakistan, I think there are a lot of areas that need to improve. Number one, we really don't have any centralized epidemiological intelligence network that can preempt this kind of infections or other diseases, communicable as well as non-communicable. And it's high time that we produce something like CDC in Pakistan, which can actually preempt what is coming and can foresee. I mean, it is also ironic and sad that we are 2 years into an epidemic, and we are still running an ad hoc mechanism of NCOC, which obviously has done a tremendous job, but NCOC is not our solution. We really need to create a system of field intelligence officers of epidemiologists. You know, CDC has really created a beautiful model that we don't need to reinvent the wheel. Obviously, we are not America, so we have to just look at our own resources, but at least we need to head in some direction. Now, in 2020, they had passed a resolution. NIH was supposed to be remodeled and revolutionized, and all these diagnostic facilities and CDC kind of things were supposed to be put in place, but nothing has happened. Why? What are we waiting for? When are we going to produce our own vaccines? When are we going to produce our own diagnostic tools? I think this platform, I think I would very seriously request people who are in the seat of authority to sort of pay attention to where we are. And we do not want to remain as a consumer society. Our kids perform the best when they go across the globe. We have the best scientists. The heart transplantation in United States in the last couple of weeks, one of our colleagues, Masood, had been working for the last 30 years on this. So we have the brains. Pakistan has produced the best brains. It's time that we create an infrastructure in Pakistan where we can put all these brains together, support them, take them forward, and create a safe, economically viable, and a feasible environment to prevent these things from happening. I think there were a lot of mismanagements in that dealing of this epidemic. We could have done better, but we were obviously not prepared. The whole world was not prepared. And I think compared to the rest of the world, we probably have done a lot better than what we would have. And I think a lot of credit of that goes to Allah subhanahu wa ta'ala and to our young generation. We are lucky that our population is very young, and that's why we have so little morbidity and mortality compared to the West. But I think our team has worked well, but we don't want to stay as a consumer society. We need to be doing economically viable research. We need to be producing medications. We need to be producing monoclonal antibodies. We need to be creating a whole system of surveillance, because these eventually pertain to our national security. These are national security risks. And this is why United States invests so much money on CDC, which is not only collecting its own data, but keeping an eye on the rest of the world, is not because of they really love the world, because their own security. So it is our national security also which is at stake because of these epidemics and pandemics and whatnot. So I think I would like to conclude by saying that this epidemic gives us tremendous opportunities. This gives us tremendous ways of thinking. World has become a global village. We have learned a lot of things. We have collaborated with a lot of things. It's high time that we develop our own infrastructure of field epidemiology and intelligence setup. We create a centralized, centrally controlled mechanism to look at our communicable and non-communicable diseases, because again, we have been working through the platform of PKLI. One of our major mission was to cure people with existing Hep C, so we don't turn them into a transplant candidates. That's where the money is. And I think if we focus ourselves in enriching and improving our skill developments towards doing some real basic research, it's ironic that we are 2 years into the epidemic and we don't have many gene sequencing labs in the country. Why not? I mean, this is no mega technology, and it's a very simple thing that commercially viable research. I mean, we should be producing our own vaccine. We should be producing our own drugs. So I think this epidemic has really given us perspective that how to prevent things, how to preempt things, how to create infrastructures. And I think with the people sitting as other speakers and the listeners, it's my humble request and suggestion that we just don't finish this conversation here and just say goodbye, that we should actually then come up with some strategy that where we can really put things in place. And this is not possible without the state support. This will never happen if Indus Hospital or PKLI or Shifa Hospital or Al Khan can do it on its own. It has to come a pyramidal structure coming from state as a central this thing. This 18th amendment has already done us some damages. One of them is health policies and regulations. It has to be a central phenomena where we can deal with the rest of the world and start to improve our services so that we can better manage our we can better preempt, we can better predict what's coming. And this does not only pertain to communicable diseases. I'm talking about the non-communicable diseases. The graph is going down and down, and we cannot afford, as an epidemiologist and as a public health supporter, it's my burning and strong desire that we create a system of prevention in this country
Thank you.
and for both communicable and non-communicable diseases.
Thank you.
And I want to thank you for letting me participate in your conversation.
Thank you, Dr. Saeed. As always, it's a pleasure, and it's a learning opportunity always. Whenever we listen to you and your attend your talks, mashallah. And again, we are really privileged to have someone like you in Pakistan, who's contributing just like so many others. You actually mentioned that the role of technology. I think that is something which all of us will talk about, because we have kept in the conversation as technology is one of the two opportunities or the silver lining in this situation. And I'm sure other speakers will talk about it more. You also talk about the need for an organization or institute like CDC. So, since you have talked about research and development, and we know that today's conversation is around creating a healthcare ecosystem, and that's why we have invited representatives from pretty much most of the important areas. So we have vice chancellors, we have industrialists, we have regulators, we have clinicians who are providing healthcare services, and we have the College of Physicians as well. I would like to. I just see that Professor Khalid Saab has joined us, and so Khalid Saab, would you like to start uh, and uh, and talk about the healthcare ecosystem, the challenges, the backdrop which we have created, that we have this double disease burden, we have physicians working in silos, we have the physician burnout, and we have antibiotic resistance. So there's so many challenges, and as Dr. Saeed said, chronic disease. So Pakistan, unfortunately, has become the fastest growing country in the world when it comes to diabetes. It is ranked third in volume, although Pakistan is not the third largest country in the world. But the rate of growth of diabetes has brought Pakistan again in the top. So these are alarming situations specifically for Pakistan. But from a College of Physicians perspective, from an education perspective, I would request now Khalid Gondal Sahab to introduce himself, and then talk about the challenges and also the opportunity revolving around technology and patient-centeredness. Over to you, Khalid Sahab, please.
Thank you very much, Dr. Zakiuddin Ahmed साहब. I think this is one of the most important seminar. और मैं अगर थोड़ी सी ये request कर दूं, I've just left a syndicate meeting of one of the university, and I'm going to King Edward Medical University. I'll be there in next 15 minutes. और अगर आप एक स्पीकर को मेरे से पहले ले लें, तो मैं 15 मिनट के बाद अपनी यूनिवर्सिटी में वीडियो कॉन्फ्रेंस पे आ जाऊंगा, और मुझे अगर आप 5 से 10 मिनट की स्क्रीन शेयरिंग की फैसिलिटी दे देंगे. I just wanted to share some innovations in the technology which we developed during this COVID challenge, and as the opportunity in the form of the telemedicine and few other things I would like to show in the in 10 minutes, if you allow the screen sharing. Or isme I think after 20 minutes I'll be like to discuss the things which you have just mentioned. 20 मिनट के लिए मैं गाड़ी में बैठ के I'll remain observer, और 20 मिनट के बाद I'll be there in my office.
Sure. ठीक है, डॉक्टर साहब, बिल्कुल हम we would love to take you back, and you can stay and listen to the conversation. So I would like to now jump to Khalid Mahmood Saab, because as Dr. Saeed mentioned, the role of research and development, and he mentioned genome sequencing, and we know that the cost of genome sequencing has come down from millions of dollars to around $100, and we get the tests immediately. So this shift, could not happen if one of the major stakeholders in healthcare, which is our industry partners, if they don't play their role well. And we have seen, as Dr. Saeed mentioned again, why are we not developing our own diagnostics? So I would like to invite now, bring Khalid Mahmood Saab in the conversation. Khalid Saab, please give your introduction. I know that you have worked in healthcare, in addition to being an industrialist and a pharmaceutical executive. you have some experience in healthcare as well. So, Khalid Saab, if I think we have lost him. So we will, yeah, we are reconnecting. So Khalid Saab will be able to, I think, reconnect maybe in a minute. So if not, then we'll move to our other speaker. Yes, I think we have him back. I wanted Khalid Saab to actually create this connection with what Saeed Saab started, and then we bring Arshad Taqi Saab and Gondal Saab together at a later stage. So let's just wait for another half a minute, and if Khalid Saab can join, then we will start with him. We are having some technical problems with Khalid Saab. So, okay. Dr. Arshad Taqi Saab, are you there? We cannot see you. I think your video is also blocked. If you can turn on your video as well, Dr. Saab.
Oh,
I
you want
apologize
me to come back in and
Doctor. Is it Dr. Arshad?
because I didn't really know at what time was supposed to speak, so I was
Ji.
ready. But I can join in now. Yes,
Okay.
I can make
So-
myself available in now.
Okay, great, Dr. Saab. Thank you very much. So, Dr. Arshad Taqi Saab will introduce himself, and with the backdrop which we have created with the conversation which we started, I would request him from his perspective and from the position which he enjoys, which is brings a lot of responsibility, I would say. So, Dr. Saab, please introduce yourself, and then over to you for the next 10 minutes. हैं? खालिद साहब आ गए?
जकी आप म्यूट हैं, अब आपकी आवाज नहीं आ रही है डॉक्टर जकी.
Ji, bilkul. So, thank you very much, Ji. Thank you. So, I was saying that we are having technical glitches at the speaker's sides. So, maybe without wait, hum nahi karte. Dr. Bari, can we start with you so that Dr. Arshad and Khalid Saab join us?
Okay, I think so.
Please. Thank you very much.
So, Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Assalamu alaikum. Zaki, it was a nice presentation, and Dr. Saeed Akhtar covered most of the things. I will just, because as Pakistan, unfortunately, we are on top of every health indicators, be it maternal mortality, be it infant mortality, malnutrition, still death, unfortunately. And as you said, we are the fastest growing diabetic nation. Number 1 in the world, and number 3 in the world is the diabetic load is. So be it communicable diseases or non-communicable diseases or malnutrition. So when we were starting Indus Hospital, which was in 2007, we realized we were asked, people were skeptical about the existence and why we want to do it. And people were saying it is the responsibility of the state to provide the education, and health is the state responsibility. But in 2007, Pakistan's was about 60-year-old, and the healthcare scenario had not changed. People worked, advocacy was done, there were strikes, there were agitation, but unfortunately, nothing happened. So we decided that at least we should start a parallel system which works. And the healthcare is basically, and when we'll go to our hereafter, we will not be asked by the, Allah will not ask us about the government, but they have not doing it. They will ask what you have done. So then we decided, and our mission was to provide comprehensive healthcare. So by comprehensive healthcare, as Dr. Saeed rightly mentioned, that we start from the preventive side to the quaternary care. And it is, if you take a primary healthcare, the investment, return on investment is much more if you spend on your preventive healthcare than it's an inverted pyramid. More finances in tertiary care, less beneficiary, less finances in the primary or preventive side, and more beneficiary. And unfortunately, the healthcare of Pakistan has been unregulated industry from since till recently, about a few years ago, when we have now healthcare commissions in all the provinces and in the federation also. But they are in infancy, unfortunately, infancy, and they have a double standards for public health and a private health sector. So the load, the challenges of healthcare in Pakistan is so great that not a single sector can help to resolve it. So it has to be a collaborative effort between the public sector, private sector, not-for-profit sector. Unless we work together, we are not going to achieve these health indicators will not be, we will always be in first three. So we have to end the COVID situation in Pakistan. So there were crises, and as we say, from crisis, we have opportunities. And that was, I was asked one journalist from India called me and said, so we are the same nation, demography is the same, our behaviors are the same, but what Pakistan did differently than India, that we controlled this pandemic. So one thing which I think which was very important was we have a coordinated NCOC mechanism where all the federation and the provinces were integration with consultation with each other. And the other thing which we had a very strict lockdown from the beginning. What India did, they closed whole of India. So, but they asked all of the people to go into their homes. So they took from urban areas to the rural areas, which Pakistan, because of lockdown, inter-province, inter-city transport ban, it became an urban phenomena. The other thing which you mentioned about the technology. So when we started, so from day one, the first hiring which we did was the software engineers. So we started as a paperless hospital from day one. Unfortunately, what we lack in Pakistan is data. We don't have data. Whatever efforts we make into the healthcare system is the wishes of the leaders. So he sleeps, the prime minister sleeps, and the next day he says, we will start liver transplant all over Pakistan. So without taking into consideration the preventive side also. And Zaki, you very rightly mentioned that it should be the patient-centric approach. And one of your slides said it's a triple aim, and now you said quadruple aim. I think so. It should be people-centric. Unless you have people-centric, then you cannot. The working conditions for the healthcare workers, the well-being of the healthcare workers, the patients, and the staff, the attendants who are patients. So, and then you can achieve your this goals. So, and the other thing which the curriculum, our curriculum doesn't taught us, it doesn't taught us passion, ethics. In the curriculum has to be there, unless those who are they have tarbiyat from their family, so they become doctors like Saeed Akhtar, other like. So this, whatever we have learned from the use of technology, the private-public partnership, unless Pakistani nation is a very different nation. So whenever they are in crisis, the response of the nation is totally different. Be it an earthquake of 2005 or the flood of 2011, 2010. So you have seen the response of this nation. And the similar response has come during this COVID situation in the last 2 years now. And I hope that whatever we have learned during this pandemic, the normal days also, out of crisis, we should be the same nation whatever we are in the crisis situation. So I think so. This is what I can say. And the technology, I know technology, the data, and the other thing which the sharing of data among the institutions. What we need, this country need one healthcare HMIS, and the medical, your health card, your national ID card become your medical MR number. So wherever you go, you just put in your MR number, your ID card number, you will get all the data for your medical, any hospitals. So we should not shy away of sharing. Unless we don't, we will not be able to improve the healthcare system of Pakistan. The other important aspect which Dr. Saeed Akhtar mentioned about the R&D, and it is, as he rightly said, it is the national security of Pakistan. We all know we are an atomic power, same as India, but both the countries know that they will not use it. But unfortunately, the Khalid Saab will definitely vouch, and he will let us know that all the raw material for medicines we have to import 100%, and majority is from India and China. If India stops giving us exporting the raw material to Pakistan, it will become a crisis. So I'll end up there, and I think so with people sitting around, and I totally agree with Dr. Saeed Akhtar, at the end of the plenary session, we should come up with some recommendations for the state to develop a better healthcare system for Pakistan. Thank you.
Thank you very much, Dr. Bari. Thanks for giving a perspective. And as you rightly mentioned that, Alhamdulillah, Pakistan fared well during COVID. It was the blessing of Allah subhanahu wa ta'ala, but also, I think, very prompt and proactive response from all the stakeholders, from people in the government, healthcare professionals, alhamdulillah, the society at large. So I think we need to celebrate that as well, keeping in mind the challenges. But the numbers in Pakistan compared to our neighbor obviously tells us a lot. So thank you, Dr. Bari, for your perspective. And again, I apologize to the participants and audience about the technology glitch which is taking place. Sometimes it's beyond our control, but the team is trying to handle that, and inshallah, it will be resolved. So, may I ask Khalid Mahmood Saab is if he's there, and if he can start. Khalid Saab, are you there? We are having trouble hearing you, Khalid Saab. Yeah, this is quite unfortunate because all our speakers had prepared their talks and they had so much to share, and this is the first plenary session of the conference where we deliberately invited the top leaders in healthcare from all over the country, because we wanted our audience and participants to learn from these visionaries. So let us continue to work around the technology issue. Khalid Saab, are you able to speak? Because we cannot hear you, unfortunately.
Zaki, if you can ask him to speak through a phone, maybe it's using too much of the data. So if the picture is not there, it may work actually.
Ji, unfortunately, we are all connected in one platform, which is StreamYard. So the team is trying to bring the speakers. Can we have speakers on phone? Because obviously our speakers are struggling. And so Arshad Saab, are you there? Can we request you to join in, Arshad Saab? No, I'm afraid that both our speakers are unable to connect. Khalid Saab is also, I think, on the way.
Yes.
Ji, I think Khalid Mahmood Saab is able to now join us.
Yeah. Can you hear me now?
Yes, Khalid Saab, loud and clear,
Okay.
and we can
So,
see you, we can hear
I
you.
am-
Please start.
I've turned off my computer, and I'm on my phone, talking from my phone. Is that okay? Can you hear me? The voice is important.
Ji.
The face isn't.
No, we can hear you and we can see you. All is good now. So Khalid Saab,
All
please
right, thank
introduce yourself, and then you have 10 minutes. Please share your thoughts on the topic.
Thank you. So my name is Khalid Mahmood, and basically I'm the CEO of Getz Pharma. I lived in the United States for 15 years, and I had an opportunity to work in somewhat in a primary healthcare with a company called organization called PATH, Program for Appropriate Technology in Health. That was the WHO Center for Collaborative Research for HIV and Hepatitis. And I worked, of course, in the pharmaceutical industry, and then I came back and set up this company. So I will speak and present my thoughts as a Pakistani citizen, very concerned with the state of health and with improving the healthcare of our citizens.
Hello.
And
Testing.
hello. Can you hear me now?
We can hear you very well, sir. And you can turn on your video as well if you want. We would love to, look at you while you speak.
Okay. All right. Sorry.
Thank you.
Okay. No, it's okay. Let me just... So I will basically very concerned that Pakistan is blessed with one of the best, not one of the best, but basically a pretty decent basic healthcare units, which is present in every union council of Pakistan, and a very elaborate lady health workers system, which are also from 5 to 10 kilometers. However, it's very painful to see that what is the health of our nation. What is even more painful is that I did a small survey with some with a number of practitioner health with clinicians, GPs mostly, and even some health economists, and they did not know the state of the health that Pakistani health care system is. What is even more more painful is that once I was invited as an advisor to review some of the budgets of a very decent university of sciences in Pakistan. I shall not name that university, but what I saw to my disappointment was that every research project was being written which had no relevance to Pakistan, which had funding from abroad and local, and they were trying to develop the next amazing magic medicine in the areas of health, in the areas of cancer or other diseases. Now we all know that that is not going to happen, and in Pakistan for quite some time, and it requires several $billions to develop one. And our primary healthcare system is broken. We have no idea what is the strains of with no formal research, at least, that has been done on the strains of various viruses, on the type of cancers and its epidemiology. It's and so therefore I was a little they started me to think of how, and I think Dr. Zaki's presentation basically asked what is wrong and how can we change it. I think I will touch on that, but I think that from my point of view, that our country ails with a system where we are not working on developing the and allocating resources to the primary healthcare, but we are allocating resources to the treatment and the tertiary care. And tertiary care, everybody knows, and I think I'll be teaching. I don't. I'll be the luminaries that present here. They know better than anybody else that for every $1 or $20 that you spend on the primary health care, if that it turns into a disease, you spend almost about $300, and that is a great burden on the healthcare system. The question, of course, is why is Pakistan, which is a nuclear power country and has such amazing kind of health and people like Dr. Saeed Saab said that when they go abroad, they become a Dr. Saeed, and of course here too there are so many of Dr. Baris and everybody and the other luminaries who are here, but still our healthcare system is bad. So I think that the first step to changing anything is to first know what is the state of health, what is the state of health of a nation. So I think for it, I'll just take half a minute and recap that we have to take a look at the UNDP's Human Development Index. And the Human Development Index ranks Pakistan as 154 amongst 89 countries that they studied. And of course, what is and they looked at the HDI. So unless the HDI improves, in my opinion, my recommendation is the healthcare system will not improve. Of course, what is HDI? HDI is, of course, a composite of the life expectancy or average predicted age of a citizen at birth, education, or the which is measured by the number of years of schooling of citizen. And the third and most important is the standard of living and purchasing power of a citizen, which is measured by the GNI of a country. GNI, of course, is a gross national income, which is an index which measures the standard of living in a country by looking at all the money earned by a nation or a population. Now, Pakistan, according to HDI, UNDP's HDI, ranks very, very poorly in life expectancy. We have 67 years as compared to almost 73 years in Bangladesh, and about 77 years in Sri Lanka. So in education, of course, the average schooling that Pakistani gets is 9 years as compared to about 11 years in Jordan, and 12 years in Bangladesh, and 14 years in Sri Lanka. Now, the third most important and the most important is the GNI rating for Pakistan is also the lowest as compared to regional countries. 75% of Pakistanis of earning age, they live under the poverty line. In Jordan, it's only 18%, Philippines 55%, and Sri Lanka 40%. I remember the days when Philippines was called, when I used to go to Philippines to set up the business and for some projects, and it was called the sick child of Asia. Pakistan was not called the sick child of Asia, and I think Pakistan is now a very sick child of Asia. So I do not have to mention to this august gathering of the luminaries of health and scholars of public health about the state and stage of the diseases of each one of these categories. If you look at each one of the poverty-based diseases, the communicable diseases, and the non-communicable diseases, we are one of the highest in terms of diabetes. As all of you have mentioned, we are way up there, and by 2045, we are forecasted to be ranked number 3rd, and number of diabetics in millions. And today, even we are 1 in 4 of us are diabetic. So now, how the question, of course, is that what is to be done? I personally feel that yes, technology is one part, and but technology, affordable technology. We all know that today, Pakistan in the field of cancer does not even make 1 TINEB, in the oncology section. We do not, and there are so many reasons, and I'll just come back to health, and I'll say that we can only change the system if every citizen, whether a doctor, lawyer, lawmaker, or businessman, understands what is Pakistan's gross national income and how much of it we spend on health and how much we spend on not spend on health and education. So development economists and scholars have been pointing out 2 remedies. One is that for a while, that unless Pakistan makes structural changes in its tax system, in its industrial system, it will not be able to increase the manufacturing, and only a country which can export and increase taxes, provide employment, and increase in education can have the resources to spend on health. Pakistan used to spend 0.8% of GDP on health, then it went up to 2.6, and I think I was looking at the World Bank statistics for 2021, and it has gone down to 1.6% on health, of GDP on health. But I mean, countries like Sri Lanka spend more than twice that of ours. Country like Malaysia spends more than 4 times of ours. Our tax system is such that we have the lowest per capita tax to GDP ratios, one of the lowest per capita tax to population ratios. I work extensively in Malaysia. I have set up a API manufacturing facility in Malaysia for oncology, and I know some of the basic statistics there. And a country of 30 million people collect 12 to 18 trillion rupees of taxes. We with 220 million people collect only 4 trillion rupees of taxes. And I think this is because there are some sacred cows that our system has nominated. One of them is, of course, agricultural income cannot be taxed, even though it's one of the largest contributors to the economy. And of course, the second one is the traders do not pay any tax. And third, of course, is that the real estate. Eminent economists recently have said that the Pakistan's official estimates of 3 trillion rupees in the assets of real estate are not 3 trillion rupees, it's 300 trillion rupees. So unless, so as a result of which, the tax burden comes on those who are already paying taxes, which are the medical community, which is the pharmaceutical community, and as a result, people are investing then not in technology, but they're investing in real estate. Now, if that continues, I think that technology will not develop. If you look at the vaccine manufacturing from the ground up, a full cycle where you do some biological work, some biotechnology work, requires 50 to 100 million dollars of investment if you're serious at manufacturing. But unfortunately, every government has changed the policies. They make a policy, then they within 5 years they break it. Even today, as we are talking, the government is talking about changing some policies based on which some companies had invested. And if the business community will feel and they conclude that no policy is permanent, and it's everything is ad hoc, then I think people will not invest in hospitals. People will not invest in technologies, and of course there'll be a brain drain, and of course there will be people who leave. Karachi, of course, we all know that had a very few. The last proper big private sector hospital was built I think 40 years ago, and of course the large government hospital also built that long ago. It's thanks to Indus hospital
Gee,
and that we have done. So I think
right.
the bottom line that I'm recommending is that we must spend and allocate our resources in primary healthcare rather than
Thank you,
tertiary
sir.
healthcare. Thank you very much.
Thank you, Khalid Saab. And again, the beauty of inviting different stakeholders in the panel is that they bring different perspectives. So the diversity has really contributed to the conversation, and I'm so happy that you brought the HDI and GNI in the conversation. So thank you very much. That was a brilliant perspective and an insight which helps us to understand how we can collectively and jointly help in developing and improving healthcare in Pakistan, not in isolation. So
Just
we
wanted to
need to
thank you,
manage
Dr.
time.
Saeed. Just wanted to thank you for inviting me. It's a great honor to be here and be with people like Dr. Bari, Dr. Saeed. I'm great admirers of, and for a number of other great contributors to health. Thank you very
Thank you. Thank
much.
you very much. Please stay with us, and I will quickly move to Dr. Arshad Taqi Saab. We want to manage time as well, so 10 minutes to each speaker because we are moving closer to the Juma prayers also, and we want to close by 1 p.m. max, inshallah. Despite the technology glitches for which we are extremely sorry. So Arshad Saab, I see you are ready, and please introduce yourself, and over to you, sir. Thank you. Arshad Saab, if you can just maybe try to turn off your video and because we cannot even hear you now. Yes, let's try again.
Can you hear me now?
Yes, we can hear you, sir. Please carry on.
Can you hear me? Right. Thank you for this opportunity. That's wonderful. Without wasting any time, thank you for giving me the opportunity, and it was a pleasure listening to all the speakers who spoke before me. It was enlightening. Pakistan Medical Commission. So I'll just talk with reference to Pakistan Medical Commission. Otherwise, I'm a clinician. I'm a anesthesia.
Dr. Arshad, again, unfortunately, we cannot hear you.
Dr. Zaki, if
So,
I can suggest that if you can ask him to call you on your phone and you put him on your speaker, we'll be able to hear him.
जी, that's a good idea. Doctor, मैं उनको मैसेज करता हूँ because we do want to hear him. मैं उनको भी कहता हूँ. जी डॉक्टर साहब, मैं आपको फ़ोन पे ले लेता हूँ और यहाँ पे मैंने स्पीकर ऑन किया है, तो हम इसको थोड़ा सा इम्प्रोवाइज करते हैं और आप प्लीज़ जारी रखिए. जी, आपकी आवाज़ फ़ोन पे आ रही है. जी जी, आ रही है. प्लीज़ कैरी ऑन. आ रही है आवाज़?
थैंक यू वेरी मच. सो आई डोंट नो कि कहाँ से मिले, तो मैं शुरू से आगाज कर दूंगा.
जी प्लीज़ शुरू से आगाज़ करें. वी कुड नॉट हियर यू, सो यू कैन स्टार्ट प्लीज़.
So, just a brief introduction. I'm anesthesia critical care clinician who has now ended up with Pakistan Medical Commission. And I'll talk about my role with Pakistan Medical Commission and give you the perspective of the regulator. So, the long and short of it is that we are interested to ensure that the country gets trained dentists and doctors. In the process, we also kind of recognize different qualification, set and establish uniform standards of basic and higher medical education and training, both in medicine and dentistry. The challenges are manifold, but I'll talk with reference to two areas, and that is licensing. So when we started off, in 2020, the most interesting challenge that we faced was that of data, because my predecessors have talked about data, so I'll talk with reference to the data. First thing that we discovered was that according to the database that we had inherited, there were 250 something thousand, 55,000 odd doctors and 28,000 odd dentists registered with Pakistan Medical and Dental Council. Out of those, we had active licenses. There were 148,000 out of those 255,000 doctors had an active license. And out of those 148,000 doctors, 90,000 something, in case of 90,000 something, we had a CNIC, which means we had credible data about their existence. So that's where we started. So the first challenge was to start collecting credible data. And we knew that the only way to do that was to shift to a digital platform. That's what we've done. We are collecting that data. Hopefully, over next year or so, we shall be able to at least have enough sufficient data to be more informed about where are the doctors, how many doctors do we have. Interesting part is that even amongst the doctors that we have on our register, the licensed practitioners, we don't know how many are actually practicing and where are they practicing and how many are actually working within the country, how many have left for greener pastures. One thing that we have really managed to establish is that there is a disconnect between the demand and supply. And the biggest and the most distressing part that we see is a shift from family medicine to specialized care. Everyone actually wants to become a specialist. There are those long queues. What we find is that probably Professor Gondal is going to talk more about it. What we find is that a lot of doctors are now waiting to become specialists, whereas nobody wants to become a family practitioner. The only people who are going into family medicine are the ones who opt not to proceed any further education and just want to work as general practitioners on the basis of the graduate degree that they have already acquired. Our second challenge, of course, is of endorsing the right qualification. We have certain control over the education and the training and the degrees within the country. A lot of doctors medical graduates are coming with degrees acquired overseas. Interestingly, in one of the countries in Central Asia, amongst Central Asian states, a country of 6 million people, what we have discovered is that there are 10,000 Pakistanis studying for their graduate degree in that country of 6 million. So that would be a challenge when these graduates come back and start asking for a license to practice. We can understand what the level of education that they have received. They hardly have any clinical training there. So that would be another challenge that we'll have to deal with. And we are trying to ensure that the process of licensing is strengthened to the extent that we can actually test them properly before giving anyone a license. As you may have heard about the national licensing exam. So what this law has done is that now the process of licensing has been separated from the process of graduate degree. So also licensing would be, acquiring a license would require sitting an exam and proving that you have reached that level of competence to be a safe practitioner. Another area, another challenge regarding licensing is the process of credentialing. Our degrees, whether they be undergraduate or postgraduate, give us specify the credentials to perform certain procedures. But as we all understand that with the changing technology and increasing level of procedures being introduced into healthcare, those or not all the procedures can be credentialed through a postgraduate degree program or a formal postgraduate qualification, and a lot of those procedures are learned through different training programs and short certificate courses. Our challenge is to ensure the presence of right kind of practitioners. That's the challenge for us as healthcare regulators, and that is the challenge of course, for the healthcare commissions as well, who are actually entrusted with the process of healthcare delivery, to ensure that we have sufficient number of safe practitioners, but at the same time making sure that besides their availability, they are also adequately trained to ensure that the kind of care they are providing is safe, and they are trained to provide that care. The other challenge, of course, is regarding the undergraduate and postgraduate medical education. We now are working in the philosophy that Pakistan, as a regulator, our job is to ensure minimum standards of education, whether they be undergraduate or postgraduate. Any institution that wishes to go beyond that level and become a center of excellence would be great. So we need not be micromanaging the process of education. We just need to ensure that minimum standards of education are being followed. So the stress would be on the quality of training. We need to ensure, so in order to do that, what we are focusing on is on the hospitals, the training, where the training is taking place, whether they be undergraduate training, it be house job or postgraduate training. We are focusing on the quality and the accreditation and standards of those hospitals where this training is taking place. Another huge challenge that we as a society has to think about is the dropout of the number of graduates. 70% of the graduates in medical colleges and in dentistry, even more than 70%, are females. And because of a lot of those social norms and other priorities, we are losing a lot of them to actually the profession, to their family commitments and all. That dropout has reached alarming proportions in case of dentistry, because less than 20% of dental graduates are actually coming to us for a license. So that really is a huge area of concern to us. We also realize that in challenges we lie the opportunities. We have the solutions there. What we need to do is get out of our comfort zones. So if we go on just self-praising and saying we are producing the best doctors by citing that we've got the likes of Professor Akhtar and Professor Bari amongst us, we need to look at statistics and the data and make sure that an average doctor that we are producing is of the quality that is required. So I'll end up there because this is probably the limit of my allocated 10 minutes. I hope that that gives us some food thought and gives us some insight into what we are delivering.
Great. Thank you, Dr. Saab. Thank you very much for a good rundown. And I'm so happy that you mentioned or you started your talk with data. And you mentioned that you have also utilized or incorporated technology. You already have a digital platform. And I think that's very, very encouraging to know.
If I may,
please.
If I may intrude, apologies for intruding. One, I may emphasize, Professor Bari, I think, talked about HIMS, and the institution has done some great job, of course, starting off as a paperless hospital. One of the accreditation standards that we have developed and which we are going to enforce within the next 12 months is that every hospital which is to be recognized as a teaching hospital, be it house job, undergraduate education or postgraduate education, needs to have an HIMS and which is integrated with Pakistan Medical Commission to actually provide us with real-time data on what the patient load is and how that is connected to training. So that's just something that I may emphasize here.
Thank you very much. I think that's a very, very relevant, very meaningful application of technology, which is need-based. And that actually links with what Dr. Bari said. And to start off with what Dr. Saeed said, that, we need to have a central, surveillance and database. And you also started with data. So I see data being mentioned by pretty much all of our speakers, the significance of data and the analysis of data. So I think that's something which we will take forward from this conversation. Dr. Saab, thank you very much. Quickly moving towards Dr. Khalid Masood Gondal Saab, who has joined us from his office. And over to you, Dr. Saab. You have 10 minutes. Please start. Give us a brief introduction, and then we would love to hear your take on the topic. Dr. Saab, thank you. डॉक्टर साहब मैं आपको भी फोन पे लेने की कोशिश करता हूं क्योंकि फॉर सम रीजन योर इंटरनेट इज नॉट लेटिंग यू कनेक्ट
नहीं मेरी आवाज आएगी आपको
अब आ रही है जी अब आ रही है
मेरी आवाज आएगी वी हैव गॉट गुड आईटी सिस्टम एंड वी शुड हैव अ गुड इंटरनेट सिस्टम
प्लीज डॉक्टर साहब जी प्लीज डॉक्टर साहब स्टार्ट करें थैंक यू
मैं ज़कीउद्दीन अहमद साहब आपका बहुत मशकूर हूं एंड आई एम वेरी हैप्पी कि मेरे भाई अब्दुल बारी साहब, अरशद तकी साहब, सईद साहब, खालिद साहब ये भी ऑनलाइन है और मैं किंग एडवर्ड मेडिकल यूनिवर्सिटी को रिप्रेजेंट करता हूं एज द वाइस चांसलर एंड कॉलेज के बारे में को और मौका मिलेगा तो आई विल डिस्कस द स्टैटिस्टिक इन डिटेल। आपका टॉपिक आज का आई थिंक दैट इज वेरी इंपॉर्टेंट एंड इंटरेस्टिंग, challenges and opportunity. I'll just talk about the COVID में किंग एडवर्ड मेडिकल यूनिवर्सिटी ने किस अंदाज में इन challenges से opportunity निकाली and we utilize the information technology. COVID February 2020 service really में we have got the 7 attached hospital and by the grace of Allah Almighty not a
डॉक्टर साहब आई एम सॉरी आपकी आवाज नहीं आ रही हम सबको। डॉक्टर साहब कैन यू हियर मी? नो डॉक्टर साहब इट्स वेरी अनफॉर्चुनेट। We cannot hear you. Let me try to take you on call. Gee, I'm trying to take Dr. Saab on call so that we can at least hear. डॉक्टर साहब, अगर आपको मेरी आवाज आ रही हो, डॉक्टर गोंदल जी, अस्सलाम वालेकुम डॉक्टर साहब। जी डॉक्टर साहब, हमें आपकी आवाज वहां से नहीं आ रही, आप फोन पे ही बात कर लेते हैं प्लीज, जैसे हमने डॉक्टर अरशद को लिया था। डॉक्टर साहब प्लीज कैरी ऑन।
ये देखें हमारी अगर
I'm trying to connect Dr. Gondal also, and hopefully we can improvise and at least.
वायरस वैक्सीन की पूरी अफादियत हासिल करने के लिए बर वक्त दूसरी डोज लगवाना लाजमी है। मुकम्मल तौर पर वैक्सीन शुदा अफराद का कोरोना वायरस से मुतासर होने का इम्कान।
हमारा बहुत स्ट्रॉन्ग है और हमें कोई प्रॉब्लम नहीं है, आपकी आवाज भी आ रही है और हमारी आवाज भी जा रही है। आपके प्रॉब्लम आपके नेट की तरफ से
जी, it is possible that the StreamYard is not working, लेकिन हम में से किसी को आपकी डॉक्टर साहब आवाज नहीं आ रही थी, तो हम यहीं से इसको at least we can continue from here if possible. डॉक्टर साहब प्लीज
मुझे बता दें कि आवाज आ रही है नेट पे कि
नहीं, नेट पे नहीं आ रही, मैंने आपको फोन पे ले लिया है और मैंने फोन जो है वो माइक्रोफोन के सामने रख दिया है, तो एवरीवन कैन नाउ हियर यू।
ठीक हो गया, अब मैं फोन पे बात कर लेता हूं।
प्लीज, थैंक यू सर, थैंक यू।
तो मैं बात ये कर रहा था चैलेंजेस और अपॉर्चुनिटी, आवाज में गूंज कम करके
अपने कंप्यूटर की ऑडियो बंद करते हैं सर। जी
अब ठीक है,
बिल्कुल ठीक है, प्लीज कैरी ऑन सर।
अच्छा, मैं बात कर रहा था कोविड एक चैलेंज था, इसको एज ए अपॉर्चुनिटी हमने लिया और सर्विस डिलीवरी में देयर वर 7 हॉस्पिटल, वी डिड नॉट रिफ्यूज अ सिंगल पेशेंट एंड ऑल द पेशेंट दे वर गिवन फ्री ऑफ कॉस्ट ट्रीटमेंट। रिसर्च की बात की, 3 स्पेशल इश्यूज ऑफ एनल्स ऑफ किंग एडवर्ड मेडिकल यूनिवर्सिटी हम लेके आए। इसी तरह हाइब्रिड मॉडल पे हमारे सेमिनार रहे, जिसमें हमने केमकाना आपसे और अपना के साथ एक सेमिनार को हमने कंटिन्यू रखा। और एक और जो चीज हम लेके आए, दैट इज बेसिकली दी टेलीमेडिसिन, दैट वाज दी इनोवेशन। और टेलीमेडिसिन में बेसिकली हमने क्या किया कि दिस वाज 20 मार्च 2020, जब गवर्नर पंजाब ने कहा कि इस वक्त आउटडोर हॉस्पिटल के क्लोज हो चुके हैं और पेशेंट को टेली कंसल्टेशन की जरूरत है। सो वी एस्टैब्लिश इनिशियली द टेली कोरोना हेल्प डेस्क और उसके बाद इसको 24/7 किया। और उसके बाद हमने देखा कि आउटडोर में द पेशेंट्स दे आर हैविंग द डिफरेंट पैथोलॉजीज, सो वी एस्टैब्लिश्ड अदर सेंटर लाइक द टेलीमेडिसिन, टेलीसर्जरी, टेलीसाइकियाट्री, पीडियाट्रिक्स, गायनी, पल्मोनोलॉजी, ऑर्थोपेडिक। ये 16 सेंटर इस वक्त हमारे काम कर रहे हैं। 8 बजे से लेकर 2 बजे तक हमारे डॉक्टर्स मौजूद हैं और इस वक्त 16,000 पेशेंट को टेली कंसल्टेशन हम दे चुके हैं। और बोर्ड ऑफ कम्युनिकेशन में लैंडलाइन, मोबाइल, व्हाट्सएप, स्काइप और ऑनलाइन अपॉइंटमेंट की फैसिलिटी भी अवेलेबल है। वी हैव गॉट 3 पोर्टल, वन फॉर द डॉक्टर, वन फॉर एडमिन, वन फॉर द पेशेंट। और इसके लिए मैं रिक्वेस्ट करूंगा जितने ऑडियंस सुन रहे हैं कि हमारी वेबसाइट को विजिट करें। ऑल दीज फैसिलिटीज एंड इंफॉर्मेशन एंड द नंबर दे आर अवेलेबल। एनी पेशेंट कैन गेट द अपॉइंटमेंट फ्रॉम एनीवेयर इन द कंट्री। तो पेशेंट्स हमारे पास ऑल द डिस्ट्रिक्ट्स ऑफ पाकिस्तान and the people from 45 different countries they contacted. I have the honor to present the same presentation on Dubai Expo. माजी में नंबर 1 सऊदी अरब के एक्सपैट्रिएट थे, इस वक्त दुबई के एक्सपैट्रिएट हैं जो मैक्सिमम हमें कांटेक्ट कर रहे हैं और 45 डिफरेंट कंट्रीज के लोग भी मौजूद हैं। आपने डाटा की बात की तो जकी साहब मैं ये बात करूंगा कि 16,000 पेशेंट का डाटा दैट इज अवेलेबल विद अस। एमआर नंबर, पेशेंट नाम, एज, सेक्स, डिजीज, किस काउंटर पे उन्होंने कांटेक्ट किया, डॉक्टर की एडवाइस क्या थी, डॉक्टर का फॉलो अप क्या था, ऑल दीज इंफॉर्मेशन दे आर देयर, और पेशेंट अपॉइंटमेंट भी ले सकता है विद इन 24 आवर, द डॉक्टर्स दे विल बी अवेलेबल। इस तरीके से the most important thing for which we are using the teleconsultation is the awareness, the counseling, the preventive measure, and there are certain diseases like जिसमें dermatology है, अपनी investigation दिखा के patient की वो therapeutic treatment भी ले सकते हैं, आउटडोर के पेशेंट का वो फॉलो अप एडवाइस ले सकते हैं, और जहाँ पे फेस टू फेस कॉन्टैक्ट की जरूरत है वी एडवाइज दीज पेशेंट टू द आउट पेशेंट डिपार्टमेंट, और जिस हमारा टेरी साइकेट्री डिपार्टमेंट पेशेंट की काउंसलिंग के लिए आई थिंक दैट इज वन ऑफ द वेरी इफेक्टिव डिपार्टमेंट। और फिर जब हमने देखा कि नहीं लोग स्टीरॉइड्स के बाद डायबिटीज जो पोटेंशियल डायबिटीज है वो एविडेंट हो रही है, शुगर लेवल जो है वो बढ़ रहा है, तो हमने न्यूट्रिशनल काउंटर एक इस्टेब्लिश किया। सो इस अंदाज में दिस इज वन फैसिलिटी जिसको रिकग्नाइज किया गया एवरीवेयर इन पाकिस्तान। AKU यूनिवर्सिटी में मुझे जाने का इत्तेफाक हुआ तो वहाँ के डीन रिजवान खान ने भी इसका तस्करा किया और डिफरेंट स्टेक होल्डर्स ने विजिट किया हमारे इस डिपार्टमेंट को। तो मैं आपके इस प्रोग्राम की वसातत से ये कहना चाहता हूँ कि एनीबॉडी इन पाकिस्तान कैन अवेल द फैसिलिटी ऑफ टेलीकंसल्टेशन by the consultants of King Edward Medical University। और आखिरी बात जिससे मैं इख्तिताम करता हूँ, क्योंकि आपने 10 मिनट की बात की थी कि हर चैलेंज एक अपॉर्चुनिटी लेके आता है, तो हमने इस कोविड चैलेंज के दौरान ये फील किया कि टेलीमेडिसिन इज द नीड ऑफ टाइम, वी आर गोइंग टू एस्टैब्लिश दिस डिपार्टमेंट ऑन परमानेंट बेसिस। इसके साथ प्रोफेसर अरशद तकी साहब, माय एल्डर ब्रदर, ही वाज टॉकिंग अबाउट द ह्यूमन रिसोर्स, द वेरियस स्पेशलिटी में द कॉलेज ऑफ फिजिशियन सर्जन पाकिस्तान, इसको भी मैं 1 मिनट में टच करता जाऊं कि कॉलेज ऑफ फिजिशियन सर्जन पाकिस्तान जो है दैट इज द मेन पोस्ट ग्रेजुएट इंस्टीट्यूशन ऑफ द कंट्री। और इस वक्त जो कॉलेज ने इस मुल्क को फेलोज दिए वो 41,203 है, जिसमें 30,365 दे आर दी FCPS एंड 10,838 दे आर द मेंबर। और जो ट्रेनिंग इस वक्त दे आर गोइंग थ्रू द ट्रेनिंग प्रोसेस वो 28,947 है। और गुड न्यूज इज कि फीमेल्स इस वक्त प्रीडोमिनेंट हैं, 57%, 43% आर द मेल, 16,353 they are female and 12,323 are the male। और accredited supervisor 4,601 और accredited hospital 339। इस वक्त जो एवरेज रेशो चल रही है सुपरवाइजर और सुपरवाइजरी की वो 1:6.4 है। लेकिन मैं जो असल में बात करना चाह रहा था, जिस तरह मैं आ रहा हूँ, दैट इज कॉलेज इज हैविंग 76 फेलोशिप प्रोग्राम। लेकिन कोविड के दौरान हमें फील हुआ कि वी हैव गॉट द डेफिशिएंसी ऑफ ह्यूमन रिसोर्स इन इन्फेक्शियस डिजीज, क्रिटिकल केयर एंड इमरजेंसी मेडिसिन। वी आर गोइंग टू एक्सपेंड दिस डिपार्टमेंट एंड इंशाल्लाह एट आवर कालाशाह कापू न्यू कैंपस ऑफ किंग एडवर्ड मेडिकल यूनिवर्सिटी we are going to establish the Institute of Infectious Disease so that we may be able to provide the human resource in infectious disease. इसके साथ telemedicine department on permanent basis, and finally Professor Arshad very I think nicely mentioned and very rightly mentioned about the training of the family physician. We do not have the referral system, and similarly we need to train these family physicians जिस तरह international एक need है और जिस तरीके से डेवलप्ड कंट्री में फैमिली फिजिशियन की ट्रेनिंग होती है। एट द लेवल ऑफ किंग एडवर्ड मेडिकल यूनिवर्सिटी वी हैव स्टार्टेड द सर्टिफिकेट इन मेडिकल एजुकेशन, मास्टर्स की तरफ जा रहे हैं, PhD प्रोग्राम स्टार्ट करवा रहे हैं, लीडरशिप कोर्सेज में वी आर वेरी ग्रेटफुल टू यू, यू आर सपोर्टिंग द डिपार्टमेंट ऑफ कम्युनिटी मेडिसिन, सायरा अफसल एंड द फैकल्टी मेंबर, दे आर वेरी ग्रेटफुल टू डॉक्टर जकी आपके और आप सब क्या मशकूर है। और यू विल बी हैप्पी टू नो that we have now created the chair of family medicine, and inshallah we are going to establish the department of family medicine on permanent basis. Thank you very much। मैं चाह रहा था कि मैं आपको लाइव डेमोन्स्ट्रेशन दूं टेली मेडिसिन की, लेकिन टाइम की एक किल्लत है। अगर ये करेक्ट हो गया तो बहुत जल्दी एक फ्लो में आप देख सकते हैं कि इसको पेशेंट की तादाद 15,637 है जिनको हम कंसल्टेशन दे चुके हैं। ये तमाम डाटा आपके सामने, आपने डाटा की बात की, किन डिपार्टमेंट ने देखा, क्या क्या उनके सिम्टम्स थे, मेल फीमेल रेशियो क्या जा रही है, दिस इज लाइव डाटा। आई एम डायरेक्टली कनेक्टेड विद माय टेलीमेडिसिन डिपार्टमेंट। सिम्टम क्या है, कॉल कहाँ से आ रही है, कॉल सिटी स्किन से आ रही है, सिटीज की कॉल दिखा दे तारिक। सिटीज में आप देख सकते हैं द मैक्सिमम नंबर ऑफ कॉल्स आर फ्रॉम लाहौर सिटी और बाकी तमाम शहरों से हैं। इंटरनेशनल कॉल का डाटा आप देख सकते हैं। The maximum number their calls are from UAE and Saudi Arabia और बाकी तमाम मालिक से you can see the call। और एंड पे जब हम जाते हैं तो पेशेंट से हम पूछते हैं are you satisfied with the performance of telemedicine department? 98% they are satisfied और 2% ने कहा we need more information।
Great.
Thank you very much Dr. Zaki। इस पे मैं और भी बात करना चाह रहा था लेकिन इंशाल्लाह नेक्स्ट सेमिनार में हम इस पे तफसीलन बात करेंगे। Thank you and thank you everybody।
Thank you very much, Dr. Saab. A very, very efficient rundown and summary of this brilliant service जो मैंने खुद भी witness की है, and we appreciate the leadership position which King Edward University under your leadership and vision जो हमने देखा कि जिस तरह तेजी से promptly आपका जो response था, I think the whole country had witnessed that, and so thank you very much for summarizing that service and bringing that into the perspective of challenges and opportunities, as all the speakers have mentioned कि जब challenges आते हैं तो उसी में opportunities definitely आती हैं। I think we are now moving towards the end of our conversation और यहाँ पर we have around 10 minutes जिसमें I will ask my speakers who are currently joined, so maybe just 1 to 2 minutes each speaker जिसमें आपके final thoughts on the conversation and listening to other speakers also, and take home message from each speaker please. So 1 to 2 minutes, starting with Professor Dr. Saeed Akhtar. What would be your take home message for us, Dr. Saab?
Thank you so much। I think ये बड़ी अच्छी आपने ऑर्गेनाइज की है। आई थिंक पहला टेक होम मैसेज ये है कि इसको बात हर आदमी इसको बड़ा क्लियरली समझ ले, स्पेशली जो लीडरशिप रोल में है। आई थिंक एवरीबॉडी इज ऑलरेडी पॉइंटिंग टुवर्ड्स दैट कि फ्यूचर करेंसी इज डेटा, एंड व्हेन यू टॉक अबाउट डेटा वी टॉक अबाउट क्लीन डेटा। बदकिस्मती से हमारे यहाँ जो डेटा कैप्चर है उसमें क्लीन और क्रेडिबल डेटा का बहुत फुकदान है, और इसी वजह से जो हमारी रिसर्च अपॉर्चुनिटीज है या डेटा को एज अ सोर्स ऑफ इनकम बनाने का जो कॉन्सेप्ट है वो उसको बहुत मुश्किलें हो जाती है, क्योंकि लॉट ऑफ फार्मास्यूटिकल इंडस्ट्रीज दे विल इंटरनेशनल कंपनीज दे विल नॉट ट्रस्ट। तो मैं ये रिक्वेस्ट करूंगा कि हम जो लीडर्स हैं अपनी फील्ड के, डेटा को क्रेडिबल और क्लीन होना चाहिए। अगर वो डेटा क्रेडिबल और क्लीन नहीं है it has no value. That's number one. Number two, the take home message है, as a nation we really have to invest on our healthcare system। और ये उस वक्त तक नहीं होगा जब तक स्टेट उसकी ओनरशिप ना ले। 1000 लोग अपना अपना काम कर लेंगे इंडिविजुअल बेसिस पे। बारी भाई अपना काम कर रहे हैं, अदीब रिजवी साहब अपना कर रहे हैं, मैं अपना कर रहा हूँ, और जितने भी लोग अपना कर रहे हैं वो ठीक है अपनी जगह पे। लेकिन अगर हमने एक्चुअली अपने मुल्क तरक्की देनी है तो स्टेट हैज टू ओन द हेल्थ केयर सिस्टम, उसके बगैर ये बात नहीं बनेगी। उस ओनरशिप में, जैसे मैंने भी कहा एज एन एपिडेमियोलॉजिस्ट एंड पब्लिक हेल्थ पर्सन, जब तक कि हम प्राइमरी हेल्थ केयर पे फोकस नहीं करेंगे हम बिल्कुल आगे नहीं बढ़ सकते। तीसरा जो टेक होम मैसेज है वो ये है कि बड़ा जरूरी है कि हम एक कंप्लीट सिस्टम ऑफ ऑर्गेनाइज स्ट्रक्चर बनाएं जो कि टॉप से बॉटम तक आपस में कनेक्टेड हो, डेटा शेयरिंग हो रही हो और कोलैबोरेशन हो। देखिए इस वक्त दुनिया में जो रिसर्च का जितना भी काम हो रहा है ना, मैं $2 बिलियन की लैब नहीं बना सकता, लेकिन मैं वही अपने सैंपल अगर लम्प्स भेज दूं, जिनके पास $2 बिलियन की लैब है, तो वो मेरे सारे सैंपल्स को प्रोसेस करके, और उनकी मजबूरी ये है कि उनके पास क्लिनिकल मटेरियल नहीं है। तो बड़ा इंपॉर्टेंट है, और ये मैं समझता हूँ अमेरिका में मेरी जो ट्रेनिंग की सबसे बड़ी स्ट्रेंथ थी वो यही थी कि जो ये कोलैबोरेटिव काम था ये बहुत ज्यादा कॉमन था वहाँ पे। इट वाज अ वेरी क्लोज लिएजन बिटवीन द बेसिक साइंटिस्ट एंड द क्लिनिकल साइंटिस्ट। ये चीज हमारे एग्जिस्ट नहीं करती, क्योंकि यहाँ पे सारे लीडर्स बैठे हुए हैं। मैं बहुत स्ट्रांगली रिक्वेस्ट करूंगा कि इस सिस्टम को लाया जाए जहाँ पे कि बेसिक साइंटिस्ट और क्लिनिकल साइंटिस्ट में एक कोलैबोरेशन बने, उनकी डेटा शेयरिंग हो। क्लिनिकल साइंटिस्ट जो है वो अपना मटेरियल बेसिक साइंटिस्ट को दे, बेसिक साइंटिस्ट उसके नतीजे में उसको रिसर्च करे, और सिर्फ पेपर फॉर सेव ऑफ पब्लिकेशन नहीं होनी चाहिए, इट हैज टू बी ए कमर्शियली वायबल रिसर्च। तो लास्ट बात जो मैं आपके रेफरेंस से कहना चाहता हूँ अगेन जब तक कि हम एक कंप्लीट नेटवर्क ऑफ public primary healthcare system, epidemiological intelligence network, data sharing, हर डिस्ट्रिक्ट लेवल पे डेटा जमा हो के वो फिर सेंटर जाए, सेंटर वाले उसको क्रिएट करें. और अभी जैसे डॉक्टर गोंदल साहब ने बताया कि उन्होंने 16,000 पेशेंट्स का डेटा जमा किया है. अब डेटा जमा हो गया है, अब इसको इससे एक मीनिंगफुल मतलब निकालने के लिए डेटा प्रोसेसर भी चाहिए आपको.
Right.
और मैं समझता हूँ कि उससे फिर हम कोई मीनिंगफुल चीज निकाल सकेंगे
Right.
जिसको कि हम दुनिया भर को प्रेजेंट कर सकते हैं.
ठीक.
ये बहुत एक्सीलेंट इनिशिएटिव है जो कि वाइस चांसलर साहब ने लिया है. लेकिन उसके साथ साथ हम सबको अपने अपने पैरामीटर्स में इस तरह बढ़ना पड़ेगा कि अगर हमने दुनिया में मिन हैसो कौम अपना कोई मकाम क्रिएट करना है, तो जब तक कि हम हेल्थ केयर में इन्वेस्ट नहीं करेंगे, उसमें सिस्टम्स नहीं बनाएंगे, उसको ऑर्गेनाइज नहीं करेंगे, क्लीन डेटा कैप्चर नहीं करेंगे, उस वक्त तक हम आगे नहीं बढ़ सकते.
Thank you very much, Dr. Saab. Brilliant, and I see a lot of synergy and overlap in these points. Moving quickly to Khalid Saab. Khalid Mahmood Saab, again, 1 to 2 minutes, 1, 2, 3 take-home messages for the audience and for all of us. Khalid Saab, आपकी आवाज नहीं आ रही. We cannot hear you. Khalid Saab, we cannot hear you. Acha, in the meanwhile, we Dr. Javed Akram Saab has joined us. Dr. Saab, good to see you, and I know you were busy somewhere and committed. So, Dr. Saab, we are now closing the session. So, और हम आपसे कुछ सुनना भी चाहते हैं, आपका जो perspective है on the challenges and opportunities. So, if you can just say something in 3 to 4 minutes, we will be really grateful. Dr. Saab, over to you, Dr. Saab. Dr. Javed Akram Saab, please carry on.
Thank you so much, Zaki Saab and Bari. And of course, it's a pleasure to see Khalid Saab. I've been asked to talk about medical education. Unfortunately, in Pakistan, medical education varies from province to province and even from college to college. I am responsible for about 140 colleges, whether medical and dental, and we are struggling to standardize the curriculum. Right now, we are in the process of standardizing it. We can
Dr. Saab, I'm afraid we could not hear what you said. आप repeat करेंगे please, Dr.
छोड़ के चले गए. उन्होंने मुझसे बोला आप मुझे बोले, मेरा था ही नहीं.
Dr. Saab, Dr. Javed Akram Saab, आपको मेरी आवाज आ रही है?
उन्होंने मुझसे बोलते रहे, मैं बोलता रहा, नहीं जा रहा था. जा रहा है, क्या करें यार.
Dr. Javed Akram, can you hear me? हमें डॉक्टर साहब आपकी आवाज नहीं आ रही. I'm sorry. मैं आपको भी कोशिश करता हूं.
फोन पे ले ले.
जी मैं ट्राई कर रहा हूं. डॉक्टर साहब मैंने आपको फोन पे ले लिया है, आप प्लीज इस पे कंटिन्यू कीजिएगा.
जी मैं कह रहा था कि स्टैंडर्डाइजेशन.
कंप्यूटर अपना बंद कर लें सर, कंप्यूटर ऑफ कर लें और इस पे बात कर लें.
जी मैं कह रहा हूँ कि हमारे स्टैंडर्डाइजेशन नहीं है. वी वेरी फ्रॉम कॉलेज टू कॉलेज, प्रोविंस टू प्रोविंस, सिटी टू सिटी. हमने बड़ी कोशिश की अपने 140 कॉलेजेस को स्टैंडर्डाइज करने की. हम ज्यादातर स्ट्रगल इसलिए कर रहे हैं कि हमें ये नहीं पता कि वेदर मॉड्यूलर हम इम्प्लीमेंट कर पाएंगे या नहीं, जो WFME चाहती है हमें करना. इसलिए कि क्वालिटी और क्वांटिटी दोनों ही मिसिंग हैं ऑफ द फैकल्टी. ऑब्वियसली फैकल्टी डेवलपमेंट इज वन major bottlenecks in that और उनकी प्राइवेट सेक्टर में तो फिर क्वांटिटी है, पब्लिक सेक्टर में बहुत सारी जॉब्स खाली पड़ी हैं, और जब आप 360 डिग्री एवेल्युएशन करते हैं तो आपको पहले इंसान अच्छे बनाएंगे तो अच्छे डॉक्टर्स बन सकेंगे। उसके लिए हमने बहुत सारे प्रोग्राम शुरू किए, और अभी कुरान पाक की हमने की, जो कि एक बहुत अच्छी चीज थी। जब पॉलिसी जो बनती है उसमें एंड यूजर्स का, स्टूडेंट्स हो या फैकल्टी हो, की बहुत कम इनपुट्स होती हैं, और इसलिए बहुत सारी चीजें इम्प्लीमेंट नहीं हो पाती। स्टूडेंट टू फैकल्टी रेशो अभी भी बहुत गलत, खराब है, स्पेशली इन ए पब्लिक सेक्टर, जहाँ 300-350 बच्चे हैं और 90% 80% सीट्स खाली पड़ी हैं। हमें ये पता है कि लड़कियां ज्यादातर क्वालिफाई करती हैं टू गेट इनटू मेडिकल स्कूल आफ्टर सुप्रीम कोर्ट डिसीजन, लेकिन वो काम नहीं करती। उनमें से सिर्फ 20% काम कर पाती हैं, बाकी तो काम नहीं कर पाती। इसलिए वो ह्यूमन रिसोर्स वेस्टेज हमें करना होगा एड्रेस। उसके बाद कैन यू हियर मी नाउ फ्रॉम द अदर साइड?
जी जी, हम आपको फोन पे सुन रहे हैं डॉक्टर साहब।
ठीक हो गया। अच्छा, उसके अलावा अब जो आपने मुझे रिसर्च का कहा था, तो रिसर्च में मैं बस 1 मिनट के लिए यही कहूंगा कि मोस्टली जो रिसर्च हो रही है पाकिस्तान में, दैट इज टू इम्प्रूव योर सीवी और टू गेट ए जॉब और टू क्वालिफाई ए जॉब। वो ज्यादातर इट इज नॉट रेलेवेंट, सो इट डज नॉट गेट ट्रांसलेटेड। इम्पैक्ट फैक्टर तो बन जाता है, लेकिन इम्पैक्ट ऑन सोसाइटी नहीं बनता। तो इसलिए वो बहुत जरूरी है कि पहले हम ये देखें। हमने तो डिजाइनर रिसर्च करते हैं, हमने तो इंडस्ट्री को बुला के प्रेसिडेंट ऑफ पाकिस्तान के सामने एमओयूज किए। हमने उन्हें अब कहा है कि आप बताएं आप कौन सी रिसर्च चाहते हैं, हमारे कोई 70 के करीब पीएचडीज आपकी डिस्पोजल पे, आप बताएं। सो अब वी आर वर्किंग ऑन दैट। हमारे पेटेंट्स बन गए, हमारा इम्पैक्ट फैक्टर बन गया, लेकिन प्रॉब्लम ये है कि मोस्ट ऑफ द रिसर्च, मेडिकल रिसर्च, रिवॉल्व्स अराउंड बायोटेक्नोलॉजी। तो पाकिस्तान में अभी तक कोई बायोटेक्नोलॉजी
जी
यूएसएफडीए से अप्रूव, मगर उनको एक भी हम कमर्शलाइज नहीं कर पा रहे। दूसरा, ज्यादातर बॉटलनेक इसमें रिसर्च में एक तो नो हाउ का है, ट्रेनिंग का है, इसलिए हमने रिसर्च पे पूरा डिपार्टमेंट बनाया। और अगर रिसर्च हो भी जाए तो इट डज नॉट नेसेसरली ट्रांसलेटेड इनटू पब्लिकेशन। दैट इज व्हाई मेडिकल जर्नलिज्म का हमने शोबा खोला, और अब हम मास्टर्स भी करा रहे हैं और पीएचडी भी उसमें करा रहे हैं। इसलिए प्रॉब्लम ये है कि आपको पता है कि पाकिस्तान बहुत बड़ा मुल्क है, लेकिन इधर सिर्फ 3 इम्पैक्ट फैक्टर जर्नल्स हैं। सो दैट इज वन ऑफ द सीरियस इश्यूज। जो ट्रायल्स होते हैं मोस्टली कॉन्फ्लिक्ट ऑफ इंटरेस्ट उनमें होता है, जो फार्मास्यूटिकल इनिशिएटेड होते हैं, तो इसलिए उनको भी हमें करना तो चाहिए, लेकिन भी व्हाटएवर इट इंडिपेंडेंटली। सुप्रीम कोर्ट ने हमारी रिसर्च पे ये सारा फ्रेमवर्क बनाया रिसर्च का, लेकिन वो रिसर्च का जो फ्रेमवर्क है दैट इज वेरी वेरी स्लो। उसमें ड्रैफ्ट की अपनी कैपेसिटी भी नहीं है इसको करने की, तो इसलिए वी आर ट्राइंग टू ट्रेन देम, बट देन आई थिंक दे नीड मोर मैन पावर एंड टू डू इट प्रॉम्प्टली। इट शुड सपोर्ट रिसर्च ऑल द लॉ, नॉट ब्लॉक द रिसर्च। तो थैंक यू सो मच।
डॉक्टर साहब, बहुत शुक्रिया आपका। हैविंग यू on any conversation is always great, always a learning opportunity. You bring a very good perspective both from education and research, and we know your contributions in research. So thank you very much, Dr. Sahab. And again, as I said earlier, कि हम बार-बार कुछ चीजें हैं वो जो हम सुन रहे हैं तमाम स्पीकर्स से, and at the end of the session maybe I will also summarize those points, but moving again very quickly to Khalid Saab. Khalid Mahmood Saab, can you hear us?
Ji, can you hear me now?
Yes, we can. Please continue, Khalid Saab.
अच्छा, so in summary जी, मेरा जो मैसेज है ये है कि I think that we need to allocate more resources on primary healthcare, taking on what Dr. Saeed says, that I've always believed that charity is always very good, and it's wonderful, and it takes the pain away from millions of people. But state का जो रोल है वो एजुकेशन और हेल्थ में charities nahi replace kar sakti. The state has to take responsibility, and of course, it needs resources, and to need resources, it needs revenues, and in order to need revenues, it has to, people have to do their share. Technology, जैसे अभी Dr. Javed Akram साहब का, I have had the privilege of knowing him, and he has done tremendous research, a lot of research, which is R&D research. Unfortunately, to transform R&D into technology, into commercialization, that's another science, there is another technology, and it needs a lot of financial resources. Those financial resources needs consistent policies by the government. हमारे इस वक्त जो है, अगर आप whatever new products are even coming in COVID, they're already available, registered, priced out in Bangladesh, and Bangladesh is exporting those medicines. A friend of mine in Malaysia has imported, and in the Far East has imported from Bangladesh a lot of anti-cancer drugs. But हमारे यहाँ जो है, हमारे country में, we have to realize that manufacturing and technology and industry has to have consistent policies, and they need we do not need handouts, we do not need incentives. All we need is the government to do their job, and then I think, mashallah, Pakistan is gifted with such brains and such wonderful education in many ways, that we can contribute to improving the healthcare indicators, which are one of the most dismal in the world. And so, and thank you for this, for inviting me, sir. And it is a very great learning experience to listen and hear to such scholars as they are today. Thank you very much.
Thank you very much, Khalid Saab. Thanks for your few pointers at the end. Dr. Gondal Saab, again, just maybe 1, 2, 3 pointers, agar aap end mein bata dein hame.
जी, thank you, Dr. Zaki Saab. I think IT का दौर है. We have to use the artificial intelligence, but not at the replacement of the clinician. They're going to support the clinician. Big data for the research. Educational institutions have to strengthen their Department of Medical Education, Public Health, and to establish the advanced skill labs. We have to introduce the concept of revalidation and recertification. And finally, our doctors should not only be the expert, but they should be the leaders of their field. And I'm very grateful to you and your organization for introducing this competency of leadership in the medical profession. Thank you.
Thank you, Dr. Saab, and thanks for mentioning the leadership initiatives. And that's why we are here. We are gathered the leaders, but we also need to develop future leaders. And I'm personally grateful to you for your vision, for allowing us to actually help your healthcare professionals to be part of our leadership plans. आखिर में मेरा ख्याल है कि हम जावेद अकरम साहब आपसे भी फिर 1 मिनट का कोई 1, 2, 3 पॉइंटर्स ले लें, एंड देन वी क्लोज. जावेद साहब. Okay, quickly moving to Dr. Bari. Dr. Bari, your final points, please.
हाँ, अच्छा, बिस्मिल्लाहिर्रहमानिर्रहीम. मेरे ख्याल में जो पॉइंट्स हैं सबके काफ़ी अच्छे हो गए हैं. पहले मैं तो शुक्रिया अदा करूँगा तमाम पैनलिस्ट का, जिन्होंने अपनी सारी बातें कही हैं, और इंशाल्लाह हम इसका एक कंपाइल करके इसका हैंड आउट भी निकालें, ताकि जो ये सिर्फ निशिस्तम गुफ्तम और वो ना रह जाए, और इसका कोई इम्पैक्ट आगे आ जाए. और ये डॉक्टर अरशद तकी ने बड़ी अच्छी बात कही कि जी ये जो HIMS के ऊपर जो उनके रोल वो ले रहे हैं, और जो इसका मौके से फ़ायदा उठाते हुए जो ये बेसिकली जो इसकी थीम थी हमारी कि बियॉन्ड द कॉल ऑफ ड्यूटी, मैं शुक्रगुजार हूँ तमाम हेल्थ केयर वर्कर्स का, जिन्होंने और उन शहीदों का जो कि जिन्होंने अपनी ज़िंदगी गंवाई, और वो एक अल्लाह ताला उनको उनकी जन्नत में आला मकाम अता फरमाए. और जो हेल्थ केयर वर्कर्स ने बियॉन्ड कॉल ऑफ ड्यूटी यहाँ पर ये काम किया, और ये इंशाल्लाह हम सब मिल के इसको एक अच्छा इसको एक और ले जाएंगे. हमारा जो पैशन जो है ना, और एम्पैथी, ये जो अरशद तकी साहब करिकुलम के अंदर ये चीज़ें डाली जाएं, ताकि हम एक बेहतर डॉक्टर हेल्थ केयर प्रोफेशनल्स प्रोड्यूस कर सके, जो कि इसको लेके आगे बढ़ें. बहुत शुक्रिया आप सब लोगों का जी इसके लिए।
फोन डॉक्टर साहब योर फाइनल पॉइंट्स प्लीज अगर आप देना चाहें.
मेरा ये ख्याल है लेकिन कि it has been a wonderful session and but it should not just remain session. I think what we need to do is we need to make it sustainable and obviously we'll be getting some minutes or whatever, but I think this group should evolve into a continuing group. हमारा मेन एक फोकस है कि research does not get translated into action.
ठीक है डॉक्टर साहब, पॉइंट नोटेड एंड थैंक यू डॉक्टर साहब.
हमारे पास इंडस्ट्री भी एकेडेमिया भी है और हेल्थ केयर एज ए होल अंडर द लीडरशिप ऑफ बारी साहब इंडस हॉस्पिटल इज वन ऑफ द लीडिंग. तो इसको एक परमानेंट बना दीजिए ताकि हम में भी एक ग्रुप बना दें जिसमें हम एक्सचेंज ऑफ आइडियाज करें और फिर हम क्वार्टरली मिल लें या जब भी मिलना है मिल लीजिएगा.
सही, ग्रेट. आई थिंक आपने एंड में जो एक एक्शनेबल जो एक हमें कॉल दी है, आई थिंक वी विल फ्लाई विद दैट, वी विल रन विद दैट. सॉरी. So thank you Dr. Saab, and now I would just like to summarize the session, close it, and मैंने जैसे कहा कि तमाम speakers actually added a significant value in the conversation, and at least I had a lot of learning and insights from different perspectives. And again, I am a student of health systems, work in different areas. जैसा कि Dr. Saeed ने बार-बार he repeated data, and again other speakers echoed the value of data and why Pakistan needs an institute like CDC, why we need to have more focus on epidemiology and surveillance. So I think that's one major take home and message from Dr. Saab. Khalid Mahmood Saab talked about a very different perspective. I think the health economics and the overall well-being of the nation needs to be considered as part of healthcare planning. That healthcare planning cannot take place in silos. Only improving hospitals will not improve healthcare. Healthcare is much more complex, as we witnessed in one of the slides. जो Professor Lucian ने कहा कि we have still not figured out how to make it work well. So I think that perspective from Khalid Saab, as a major stakeholder in the conversation, was really helpful, and it gave us an insight जो कि हम physicians या clinicians या healthcare system में जो काम करते हैं वो we tend to ignore at times. So thank you Khalid Saab for that, for bringing that into the conversation. Gondal Saab has led the telemedicine revolution. He presented a brilliant way two areas. One was obviously technology, the adoption and use of technology. I think that's a good case study for all of us, and also the role of developing leaders. So I've personally worked with him in his university in developing his senior faculty. I think that's something which we need to discuss as well. Capacity building of both undergrad, postgrad, and as Dr. Bari said, focusing on ethics, focusing on empathy. As we know, one of the studies tells us that the students, जब वो medical student first year में आते हैं, their empathy level is higher. Unfortunately, when they're leaving the medical college, their empathy levels go down. So what are we teaching? What kind of environment are we giving them? So I think that's something which needs to be brought into the conversation. So Dr. Arshad Taqi gave us a good insight of the process, where obviously we need more conversation on that. But we are happy that he is also focusing on data and a digital platform. And as Dr. Bari reminded us, agar teaching hospitals, all teaching hospitals are mandated to have hospital information system, EMRs, and that is linked. So we create a national system where data flows and we get access to data. And as Dr. Saeed again said, not only data, but clean data so that we can analyze it. And again, going back to Dr. Gondal, that using artificial intelligence, using technology, which is available as a tool to our policymakers. Dr. Javed Akram, again, with his brilliance, mashallah, I think he has led the research in Pakistan to a large extent. And as he said, that research for the sake of research, nahi, balki as Dr. Billu, जो हमारे Health Research Advisory Board में chair हैं, as he always says, relevant research, and as Dr. Javed Akram said, relevant and research जो कि आप translate कर सकें. So in our recent conference on patient safety, we used the theme implementation research. So I think that's something which all of us need to focus on, that doing research only, उससे बेहतर यह है कि हम translational research और implementation research की तरफ बढ़ें together. Last but obviously not the least, as Dr. Javed Akram has suggested, and as the moderator of this session, I take this responsibility of compiling the whole session discussion and the outcome. So I think that's a paper which we will develop, and this will be one of the outcomes of the conference. So Dr. Bari, thank you very much for giving all of us the opportunity to sit together, talk about serious issues in healthcare, because it impacts each one of us and our families. So one outcome will be that we will have a kind of a white paper, but the other outcome, जैसे Dr. Javed Akram ने suggest किया, we will have a forum. We can call it anything we want. We can discuss together, a think tank or a forum of healthcare leaders or professionals, जिसमें we will definitely add many more people जो आज नहीं थे and who are experts in their own fields. So two outcomes of today's conversation is that we will have a paper inshallah, and we will have a forum जिसका हम जो भी नाम लेंगे और उसमें हम तमाम लोगों को शामिल करके we will continue this conversation. We will bring more stakeholders on board so that we all learn from each other. So the final point will be that I hope that government owns healthcare as the most important priority area. I hope that we have a national health policy, जैसा कि a few of our speakers mentioned, or we have an integrated national health policy as opposed to policies and strategies which are in silos. One province is following one thing and the other. So I think that's something which we all need to work together on. So with that, I again thank each one of the speakers, Dr. Javed Akram Saab. All of you are very respected, senior to me. Khalid Mahmood Saab, Dr. Bari for giving us the opportunity, Dr. Saeed Akhtar Saab, Dr. Gondal and Dr. Arshad Taqi Saab, all of the speakers for taking out time. I apologize for all the technology glitches which disturbed the conversation, but as you know, as a resilient nation, हम improvise भी करते हैं alhamdulillah, और हम इसी challenge में से opportunity निकाल के हम अपने objectives achieve करते हैं. So despite the challenges and limitations, I think we had a very meaningful discussion. I hope that the audience, whoever was listening, benefited from it. I'm sorry we could not take questions because we are running out of time now. And I look forward to having similar conversations in future. And again, perhaps in the ICON 2023, we will gather and have the next level of this conversation, inshallah. So thank you very much. I thank the team, the technology team, and the organizers, Dr. Kashif Shazli, Dr. Amar Hamid, जिनकी leadership की वजह से ये plenary session was developed. And I'm grateful to Indus hospital organizers for giving me the opportunity. Assalamu alaikum wa rahmatullah.